This conference will now be recorded.
Okay, so this guideline that came in 2024 has certain major changes regarding the investigation and management of SGA and FGR. Right? Let's look at the major highlights in the current guideline. One thing is the screening for risk factors for growth problems in the pregnancy would need to be screened at the beginning of the pregnancy. Smoking is highlighted in this particular guideline. Also, women at risk of preeclampsia or placental dysfunction, it is recommended that they start on aspirin 150 milligram daily at night. And this particular point is to be noted that it is recommended to be taken at night from 12 weeks to 36 weeks of pregnancy. Uterine artery Doppler is to be done with the anomaly scan that is routinely done whenever indicated. So we have categories: low risk, moderate risk, high risk categories, and they have certain recommendations that are made regarding how to screen them for SGA or FGR. We must know what it is to have a baby that is SGA and FGR and what is the difference. We must also know what is early FGR as well as late FGR. So we would be seeing all these points shortly. All right. So coming first to the definitions. Now let's look at what is appropriate for gestational age. Appropriate for gestational age is a baby that is between the 10th and the 90th centile. Okay, so we have growth centiles, which are obtained by plotting the growth of a normal population of the general population, and those that fall between the 10th centile to the 90th centile are considered normal or appropriate for gestational age, right? Then we have the SGA fetus. What is SGA fetus? Anybody? What is SGA fetus?
It's on 10th centile.
Excellent. So a fetus that is less than the 10th centile is an SGA fetus. So you have the growth plotted in this manner. Okay. So you have the growth curves which are going this way, this way, this way. Okay. So say this is the 90th centile, this is the 10th centile. Okay. Anything here is normal. Anything less than 10th centile is SGA. Anything less than 3rd centile, if this is 3rd, is what we are going to see next. That is FGR. Okay. So FGR is where the fetal size or abdominal circumference is less than the 3rd centile. Or, remember there is an or here. Okay. Or. So it is either a baby that is less than growing at a pace which is less than the 3rd centile. This is the 3rd centile. This is the 5th centile, say. This is the 50th centile. This is the 90th centile. Okay, approximately. The diagram is not accurate. Say this is the 10th and this is 3. Okay, so a fetus that is growing at this rate here is FGR. Okay, there could be a fetus which is here. This is actually SGA. However, if this fetus also has Doppler abnormalities, that is abnormal uterine artery PI, pulsatility index. Pulsatility index is nothing but the index that tells us about the resistance to flow. Higher the PI, greater is the resistance to flow. So if there is PI greater than 95th centile in the uterine artery or and abnormal umbilical artery Doppler, that is either absent, reversal, or PI above the 95th centile. So if you have a baby in the 10th to 3rd centile, this part, with abnormal uterine artery Doppler or abnormal umbilical artery Doppler. When we say abnormal, it means PI more than 95th centile for the uterine artery, or abnormal umbilical is where there is PI more than 95th centile and or absent reversal of flow. All right. Now, static growth, that is, there is no definite growth velocity in EFW or AC, at least 14 days apart, is also considered pathological. Okay. So when the baby is not growing well, that means the baby is likely to have a pathological growth restriction. Now, why are these terms introduced? SGA and FGR. Remember, FGR is a pathological problem. I mean, there's a problem here. SGA, babies may be small because they are genetically small, constitutionally small. Mother is small, baby is small. So you do not know whether this is abnormal, while this is abnormal. That is why even if the baby is growing, say, on the, say, 20th centile, okay, then it is at the 20th centile on, say, at 28 weeks of gestation. Okay, then, or say 40th centile at 28th week of gestation. Then you note the growth at 32 weeks of gestation. It now comes at the 20th centile. Okay, it is growing, but the centile is decreasing. That means the growth velocity is decreasing. It should have grown this way. It is growing, but it is growing this way. Okay, that means this baby is possibly not growing to its full potential. This may be an abnormal baby. That is why static growth, where the growth velocity is lacking, okay, that would be an abnormal baby. While there may be another baby where, where you have a baby growing at the 10th centile, okay, but at 28 weeks, 32 weeks, it is at 10th centile. Here also it is at 10th centile, but it is growing. It is continuously growing. This may be a less problematic baby as compared with the previous one that I showed. So what is important here is growth velocity. Okay, so it's not just enough to look at the centiles. It is also important to look at the growth velocity. All right. So FGR, remember, is pathological. That is why it is mentioned that less than third centile is possibly FGR, because less than third centile is too small a baby. It is unlikely that a baby would be less than third centile just because of genetic potential. It is unlikely that the genetic potential of the baby would make it grow over less than third centile. Okay, so SGA may be a small baby, which is just small because of maternal factors. The mother is small, the father is small, genetic factors, constitutional factors. So it may be just small, not because of a pathology, but it may be small because it is meant to be small and it is growing. That baby you would still be satisfied with. Then FGR in a previous pregnancy is also defined in this particular guideline. When do you say this history taking is very crucial? Okay, particularly if you have a question in your MRCOG part 3 regarding SGA, it's important to ask obstetric history about previous small babies that the mother has had. Okay, so what could be history suggestive of FGR in a previous pregnancy? In a previous pregnancy, if there is birth weight less than third centile, which is definition of FGR. So if in the previous pregnancy there is FGR, if there is early onset preeclampsia or FGR necessitating birth before 34 weeks of pregnancy. Okay, so that means there is growth restriction so much that you had to deliver the pregnancy at less than 34 weeks. Or there could be a birth weight which was below the 10th centile with evidence of placental dysfunction. Now, placental dysfunction is usually noted with the help of Doppler. Okay, so if you know that she has a previous pregnancy records, the baby is smaller than 10 centile, the placental dysfunction is obvious. Okay, all of these factors have to be taken into account when you are having this particular history. Now, early FGR. Okay, early FGR is also defined. Okay, what is early FGR? Early FGR is less than 32 weeks. Okay, in the absence of congenital anomalies. Why have they said that? Because congenital anomalies may be syndromic, maybe genetic syndromes like, say, for example, Edwards syndrome. It may be just that, and that is why the baby is small. But here we are looking at those factors that are possibly placental related. Okay, so early FGR, which is placental related, could be what is the definition? When it is less than 32 weeks, remember that 32 weeks is the cutoff for early. ACEFW is less than third centile. Okay, or there is umbilical artery and diastolic flow absent, or okay, AC is or EFW is less than the 10th centile with, like we saw previously, uterine artery more than 95th centile and or uterine artery more than and or umbilical artery more than PI more than 95th centile. So what does this mean? That we know that your FGR is always something that is less than third centile. Now in early FGR, there is another thing that you need to look at. If there is absence of end diastolic flow in the umbilical artery, it is a very ominous sign and it is suggestive of placental insufficiency. Okay. Why is this? You know, the baby's placenta. Okay. This is the baby. There is the umbilical artery which goes towards the placenta from the baby. Right? Umbilical artery takes the blood towards the placenta. Now, if there is problem at the level of the placenta is not well formed, the resistance to placental flow is high. What will happen is this forward flow in the umbilical artery will be slowed down to a point that during diastole, that is when the baby's heart is relaxed. Diastole is when the heart relaxes. Systole is when the heart pumps. So when the diastole, the baby's heart is relaxed, there is no forward push for the blood because the resistance or the blockage here is so much that when there is diastole, where you actually expect to have a continuous flow of blood, the blood stops during diastole and only goes during systole. This is absent end diastolic flow. Okay, So when there is absent end diastolic flow, it means that the placental resistance is so high. And this is significant only in early FGR. If you notice, in late FGR, you don't have absent end diastolic flow reversal, very rarely. Why? It is pretty obvious, because when you have absent end diastolic flow, it means that the resistance of the placenta, or the insufficiency of placenta, is so much that it does not let the baby grow. And it happens early on because it is severe, and that is why it is early FGR. As simple as that. Okay, so that is why the definition of early FGR is either the EFW less than third centile, or umbilical artery and diastolic flow may be absent. Okay, one of these two, or when it is less than 10 centile, the EFW or AC. When it is combined with less than 10 centile, with just like previously, uterine artery PI more than 95th centile and umbilical artery PI more than 95th centile. Is this clear so far? Early FGR, everyone? Clear? Please let me know if this is clear or not.
Yes, ma'am. Clear.
Yes, ma'am. Yes, ma'am.
All right. Okay. Coming to late FGR. Now we know that late FGR, absence of diastolic flow is not such an important feature, because if it was absent, it would have been severe. And if it was severe, it would have been obvious less than 32 weeks or early on in the pregnancy. The very fact that the pregnancy has grown or reached more than 32 weeks, sorry, this is more than 32 weeks, okay? The very fact that the pregnancy has reached more than 32 weeks means the placental insufficiency is not so high. Okay, and when the placental insufficiency is not so high, you would not have absence of flow. So we don't have absence of flow in late FGR. What do we have then? We have the same definition of ACEFW, third centile applies everywhere, or at least two of the three. EFW less than 10 centile with AC crossing more than 2 quartiles on the growth centiles. Now, what does this mean? I will show you in a bit. Or CPR. Now, what is important towards in late FGR is the CPR, cerebroplacental resistance. Okay, that is important in late. AEDF, or absence of end diastolic flow, is important in early. In late, CPR, that is cerebroplacental resistance, is important if it is less, and umbilical artery PI more than 95th centile. Now, what does this mean? Let us see. Okay. All right, wait. So let me tell you first what it means, the second point here. AC or EFW crossing centiles more than 2 quartiles on growth centiles. Okay, now let's see growth centiles. Okay, this is 95th, this is say 75th, this is 50, this is 25, and this is say 5. Quartiles mean 1/4. This is 1/4. This is the second fourth. 75. Sorry, this is the second 1/4. This is the third 1/4. And 75 to 100. 0 to 25, 25 to 50, 50 to 75, 75 to 100. What is crossing 2 quartiles? When she is at 28 weeks and say 32 weeks. You have seen that at 28 weeks, her growth was at over here, 75th. And at 32 weeks, her growth is here, static growth. And this has come to 25th centile, from 75th to 25th centile. So it has crossed 2 quartiles. This is 1 quartile. This is 1 quartile. Okay, as I told you, 0 to 25 is one quartile, 1/4. 25 to 50 is the second quartile, 50 to 75 is third quartile, 75 to 100 is the fourth quartile. So when this happens, it has crossed two quartiles, 75 to 50 and 50 to 25. Okay, so this means there is static growth. All right. Also, the other point is CPR. Let's see what CPR is. CPR, cerebroplacental ratio. So normally what happens is when the placental circulation is normal, the umbilical artery flow has less resistance. Okay, this is normal. That means it is freely flowing in the placenta. The placenta allows the blood to flow. Placenta is normal in function. It freely accepts the umbilical artery blood that is coming towards it. That means the resistance to umbilical artery is less. Okay. And the cerebral flow normally is high resistance. High resistance. Okay. You need low resistance in the placental circulation because that is where the baby derives its oxygen. Remember, the placenta is the baby's lung. So that is where it derives oxygen. That is why normally you need blood to flow freely in the placenta. So the resistance is low. In the brain, you need not have such low resistance because that is not needed. Brain is just for supply of blood to the brain, baby's brain. But brain is an important organ. So when the placental resistance abnormal is when the placental resistance increases. How does the baby cope? The baby copes by keeping the supply to its important organs by reducing the caliber of blood vessels or by reducing increasing the caliber of blood vessels in the brain or reducing the resistance to flow in the brain so that the brain gets more blood as a compensatory mechanism. So what happens is this resistance reduces when there is abnormality. So this resistance increases, the baby tries to maintain blood flow to the brain by reducing the resistance of cerebral vessels. So what happens is your umbilical artery resistance increases while MCA, the middle cerebral artery, decreases. So the resistance of this to this, CPR of MCA is CPR is cerebro, no? Cerebroplacental umbilical artery is high. So the ratio reduces. When it reduces less than the fifth centile, it's abnormal. Okay, so this is what it means when we say that CPR or cerebroplacental ratio is less than the fifth centile, or umbilical artery PI more than 95th centile, AC crossing two quartiles, all right? And we know what this is, AC less than 10th centile. So in this box at the side, it is mentioned that suboptimal fetal growth may also be indicative of FGR. That means that is what we just said, that it is the growth velocity that is important and can be diagnosed when a previously well-grown fetus, that is size 10 centile and above, fails to maintain adequate fetal growth during pregnancy, right? Another important point here is that early onset FGR is relatively uncommon and it is 0.3% the incidence, with late onset being more common. All right. So this is what is early onset FGR and late onset FGR. Is this concept clear to everyone? Is this concept clear? So basically, why is this important clinically is because in early IGR, you see a lot of absence and diastolic flow. Okay, and this is something that we use to decide on further intervention. After this, we do a DV Doppler. or computerized CTG. And based on this, we decide whether to terminate or not. Okay, because if you just terminate a pregnancy that is too preterm, complicated by FGR, the morbidity to the baby is much more. That is why even with absence of end diastolic flow, we try to maintain or continue the pregnancy till such a time that we think it is no longer safe. When do we think it is no longer safe? When there is changes in the DV Doppler. The ductus venosus Doppler has changes. Now, why is that? Again, it is simple concept. Okay, so this is the baby. Okay, this is the baby. This is the placenta. This is the umbilical artery. Okay. Now, as we know, umbilical artery blood flows from here to here. This is the blood flow. Okay. This resistance increases in IUGR, in FGR. Okay. So the blood flow to the placenta decreases. Okay. Now, because the placenta does not take blood, does not accept blood freely, because there is a pathology in the placenta. So this forward flow reduces and then it becomes absent and it reverses. So what happens then? The baby's heart, which is pumping here, starts failing. And when the baby's heart starts failing, blood that gets pumped into the baby's heart through the veins, one of them is the ductus venosus, which is in the liver of the baby. The blood flow, forward flow through the veins reduces because the heart is failing. This heart is failing because this is failing. This heart is failing and it is reflecting back. It is like congestive cardiac failure that we have when we have edema. So the ductus venosus forward flow reduces. So we try to deliver the baby when there is first sign of ductus venosus problem. That means the baby's heart is now having pressure and it is no longer safe to continue the pregnancy. That is why we decide to deliver based on DV Doppler. This is the concept. Because if you understand the concept, I don't think you would forget this. So in early FGR, the resistance is such a big problem that it results in absence of flow. And because it results in absence of forward flow, there is strain on the baby's heart. That strain gets transmitted back on the ductus venosus, resulting in ductus venosus Doppler abnormality. This is the concept. Okay, so you have your absence of end diastolic flow, reversal here, and DV changes happening here. While here, the placental insufficiency is not so much. So the problem happens with the local modulation in circulation. So you have the MCA flow increasing and your resistance of MCA decreasing and umbilical artery resistance increasing or flow decreasing. Okay, and CPR decreasing. So what is used here late is CPR to monitor. Here you use end diastolic flow and ductus venosus primarily. Okay, and that is what is explained in that chart which is provided at the end of the guideline. So it makes it easy for us to understand. Now, screening. So how do we screen for risk factors for SGA? You cannot screen for SGA as such. Yes, you are screening for SGA, but first we need to identify which women are at risk of having SGA or FGR, growth problems in the baby. All women should be assessed at booking by 14 weeks for risk factors for FGR. The birth weight, gestation, and birth weight centiles of all previous pregnancies should be recorded. So this is an important point for those answering part 3. At 14 weeks, you need to screen them for growth restriction. So ask them if there are any risk factors. Ask them if there are any previous babies with problems or previous pregnancies with problems. What are the problems in the previous pregnancy that you need to identify? Can anybody just summarize quickly?
ET, FGR, and small gestational age.
Yeah, FGR, you're right. So that is, you know that the previous baby was less than third centile, or the previous baby was less than 10th centile with placental insufficiency evidence, that is, Doppler changes. Or she needed delivery early, less than 34 weeks because of the growth problem, or because of preeclampsia. Now, preeclampsia is also placental insufficiency. So these babies are likely to be growth restricted. All right. So these are the two things that you need to remember. Now, okay, about screening. When we screen for trisomy, we often screen for PAPA, alpha-fetoprotein, etc., inhibin. So when you find that the PAPA, placental pregnancy-associated plasma protein, A is low and AFP is high, or inhibin is high, you need to do surveillance for SGA or FGR because that may mean that the placenta is a problem. Note this. This may come as a SPA. Okay. So low PAPA is associated with stillbirth because of placental dysfunction, which is abruption or unexplained stillbirth with growth restriction. Okay. So women with low PAPA or raised beta HCG should be offered aspirin. So if they ask you intervention in the pregnancy, you would choose aspirin. Although this is not mentioned in the NICE guidelines, it is mentioned in the SGA guideline. NICE guidelines indications for aspirin are the fixed indications, but SGA guideline mentions this additionally that whenever there is evidence of placental insufficiency, whatever it may be, you could start aspirin. Okay. So low PAPA, high beta HCG may mean there is a problem with the placenta. So you could start aspirin. Important. Okay. Yeah. Mid-trimester screen, certain factors which are considered risk factors is fetal echogenic bowel. This is a station that comes in the MRCOG Part 3 exam. And you need to offer them serial growth scans even if everything else is normal. Single umbilical artery is also a risk factor. And on the fetal biometry, that is, when you do at the 18 to 20 week scan, you note that EFW is less than the 10th centile. In case normally you don't do uterine artery Doppler for all women unless they have very high risk. Okay, so you don't do uterine artery Doppler, but on that scan, on the 20-week scan or the growth anomaly scan, you note that EFW is less than 10 centile. That means something is abnormal. You do the uterine artery Doppler to assess for placental dysfunction. Okay, and if the uterine artery Doppler then is normal, you scan again in 3 to 4 weeks. And if the uterine artery Doppler is abnormal, you could ask an obstetric review for this patient. Okay, now this is a special case when you know that at 20 weeks itself, which is too early, you have a very small baby. So you do a uterine artery Doppler. Okay. Normally, if you do a uterine artery Doppler and you find it abnormal in high risk category, we have the chart in the SGA guideline, the new guideline. You would start screening from 26 to 28 weeks with growth scans. But here they have said that EFW is so small, you don't wait for 26 to 28 weeks, but at around 23, 24 weeks, you screen them. You do the scan again to check if it is still small, that baby. Because when it is very small at a very early gestation, it may mean genetic problem like Edwards, Patau's, those problems. That is why it is important for us to note if it is too small at a very, very early gestation. And we could offer invasive testing for such babies. Okay, we'll see that in a bit. Risk reduction. What do we do to reduce risk? Reduce smoking. Important. Always ask for smoking history in stations. Okay, and you need to refer them to trained tobacco dependence advisor. Very important for us to know. All women should continue to take the recommended 10 microgram per day of vitamin D and 400 microgram per day of folic acid, pre-conception and for first 3 months of pregnancy. Balanced energy protein supplementation is necessary, but supplementation of omega-3 long-chain polyunsaturated fatty acids does not show any effect as far as reduction of SGA or growth restriction is concerned. Okay, so the interventions, just reduce smoking, or risk reduction is by reducing the smoking, having your pregnancy supplements, and a good diet. That is all. Now, women at risk of fetal growth disorders should be considered for aspirin. Women at risk of preeclampsia and or placental dysfunction, like if you identify that they have low PAP value, they should take aspirin, or you know that from history, she has history of preeclampsia, history of severe growth restriction in the past pregnancy, etc. So these women should take aspirin 150 milligram. Now, NICE guidelines mention 75 to 150. The GTG mentions 150 milligram once daily at night from 12 weeks to 36 weeks of pregnancy to reduce their chance of SGA and FGR. Doses below 100 should only be considered in the presence of other relative contraindications to aspirin. Okay, so this clearly mentions that it has to be 150 milligram. Prevention of preeclampsia with aspirin is most effective when aspirin is initiated between 11 and 16 weeks, 6 days of gestation. Okay, low molecular weight heparin should not be prescribed for growth problem, for reduction of growth problem. So the only intervention for growth problems could be aspirin. Progesterone is not recommended. HCQ in previous placental chronic histolytic intervalosis is not recommended. So only what is recommended as an intervention for prevention, okay, is aspirin. Okay, let's come to low risk women. So what is low risk? General population. In other words, women that do not have any risk for FGR. General population without risk for FGR. So for the general population, what is recommended is that we at each antenatal appointment after 24 weeks and no more frequently than every 2 weeks. So it should, the interval between two SFH measurements should not be less than 2 weeks. Okay, so they should be offered serial measurements of symphysiofundal height. So symphysiofundal height is the height of the uterus in centimeters from the pubic symphysis to the fundus. So you measure at the visits that the patient is having the symphysiofundal height. And you check if the growth is adequate. You check for serial symphysiofundal height. You start, say, first after 24 weeks. So it can be first measurement should be carried out at least by 28 weeks, 6 days. So if she has come, say, at 23 weeks earlier, and then she comes at, say, 28 weeks, all right, at least by 28 weeks, she should have her first measurement. Okay, so after 24 weeks means at least by 28 weeks, 6 days. All right, so she should have her first measurement of symphysiofundal height. And this symphysiofundal height is not just one single measurement. You plot it again on charts, just like EFW charts, on growth charts. Okay, and if it is below the 10th centile, or serial measurements demonstrate suboptimal growth, that is, there is no apparent growth over 2 weeks, it's remained the same, then she should be referred for ultrasound. Okay, then she should be referred for ultrasound. Also, those women where you think that symphysiofundal height is not likely to be accurate, like those who are obese, those with large fibroids, those with polyhydramnios, should be referred for fetal size by ultrasound irrespective. Okay, because here you cannot really rely on your symphysis-fundal height. But when you can rely on symphysis-fundal height, the first thing is you start measuring it after 24 weeks, at least by 28 weeks, 6 days. Then you plot it on the chart. If on the chart you find that it is falling below the 10th centile, or if you think that the baby is remaining at the same SFH, it is not growing, then by over 2 weeks, not 1 week, over 2 weeks, it is not growing, then you do an ultrasound. Moderate risk. What are moderate risk factors? We will see in a bit. Okay, but when there are moderate risk factors, what to do is what we are seeing now. So they are at risk of late onset FGR. That is why they require serial monitoring of fetal growth starting at 32 weeks. Okay, and this has to be done every 4 weeks. All right, so they have to be monitored. Normally, remember, unlike what is generally believed, and most candidates say that in their stations that they perform or even otherwise, that you do a scan in the 3rd trimester. No, if the growth is normal, I mean, if the patient is low risk, there is no need to repeat a scan in 3rd trimester. However, if there are moderate risk factors, then you will do a scan at 32 weeks first and then every 4 weeks, so 36 weeks. Now, of course, if you find that at 32 weeks she is SGA, your frequency of scans will change. Then you will not do at 36 weeks. Your frequency would at least be every 2 weeks if it is SGA, if you find that this is SGA. This is for those who have moderate risk factors, and you first do a scan at 32 weeks, you find the baby is normal, you repeat the scan at 36 weeks. This is how it is. Okay, if you diagnose SGA somewhere in the middle, then your further plan for the patient would change depending on surveillance for SGA. Or if you find FGR, your plan will change further. But if you find that the baby you have screened and is normal at 32 weeks, the next scan would be at 36 weeks. Is that very clear? Clear? Yes?
Yes, yeah. Yes, clear, ma'am.
All right. All right. So if two EFW measurements are used to estimate the velocity, they should be ideally a minimum of 3 to 4 weeks. Okay, for growth velocity. Sorry. Okay. Okay, so 3 to 4 weeks. So that is why they have made the recommendations that it should be 4 weekly. But when you are already establishing it as SGA, then it can be 2 weekly. All right. Performing scans at intervals less than 14 days, less than 2 weeks, increases the false positive rate for diagnosing FGR. So you should not do it. Assessment of fetal AC may help in determining the fetus that is FGR, fetal AC. Because the first thing that reduces when the baby is not growing well is the baby's stomach, is the baby's abdominal circumference. All right. So, and headlock formula is used for measuring fetal size. High risk. What do we do in high risk category? In high risk category, we first do the uterine artery Doppler at 18 to 23 weeks at the time of anomaly scan. What I had said earlier was different. What I had said was, if at the anomaly scan you find that the EFW or the growth is less than 10 centile, whether there are risk factors or not in that particular patient, you do a uterine artery Doppler. Okay, you do a uterine artery Doppler. And then if it is normal, you again scan after 3 to 4 weeks to check if what has happened to this EFW. If it is abnormal, then there is something really abnormal. You have to seek obstetrician's opinion on that. Now this, what we are saying is different. Here, when there is high risk, there are high risk factors. When there are high risk factors, you scan those women at 18 to 23 weeks, 6 days with uterine artery Doppler. Okay. Women at high risk with A normal Doppler of the uterine artery would be treated like moderate. What were we doing for moderate? We were scanning them at 32 weeks and then 4 weekly. So same thing is done for those who have normal uterine artery Doppler. While if the Doppler is abnormal, this is what I was saying earlier, you start testing them or start monitoring them between 24 to 28 weeks, 6 days. Okay, so you start monitoring them from earlier gestation as compared with those with a normal uterine artery Doppler. They behave like moderate. All right, so this is what we mean. Let's see the chart which is provided by the RCOG. Here it tells you what are the risk factors. We have already seen what is to be done if there is low risk, moderate risk, high risk. Okay, now let's see what are those risks. What are those risks? Moderate risk, high risk, and moderate risk and high risk. Low risk means no risk. Okay. In moderate risk factors, we look at obstetric history. Can you see the yellow box? You look at here, obstetric history, okay, and the current risk factors. In obstetric history, if there is a previous SGA baby, it is a moderate risk factors. Now I'm saying previous SGA. Previous FGR would be a high risk factor. Previous SGA is a moderate risk factor. Previous stillbirth, but the growth was normal, is a moderate risk factor because that stillbirth may be because of some other factor. You don't really know. It may not be growth restriction. But if the previous stillbirth was in a small baby, it is a high risk factor. Okay, simple, right? So this is about the previous pregnancy. Now, current history. Currently, if the patient is a smoker, any amount of smoking, okay, they have emphasized on smoking. So any amount of smoking is a moderate risk factor. If they are drug abusers, okay, those who are more than or equal to 40 at booking, BMI is less, that is 18.5, and there are other features of eating disorder, bowel disorders, etc. It's not just enough to have BMI less than 18, it is BMI 18, less than 18, and other abnormal problems. Okay, and when there is gastric bypass surgery, all these things are similar. So BMI less than 18 with eating disorders. Gastric bypass surgery will also cause an eating problem. Okay. Previous preterm birth or second trimester loss, okay, which may be placenta mediated. It appears that the previous loss is likely to be because of, say, antiphospholipid antibody. That is placental mediated loss. Okay, so then it becomes a moderate risk factor. Previous loss because of cervical incompetence will not be moderate risk factor. Previous loss because of placenta mediated factor will be a risk, moderate risk. Okay, so these are the moderate risk factors. What are the high risk factors? High risk factors would be maternal medical problems like chronic kidney disease, hypertension, autoimmune diseases, complex cardiac diseases. These are stations you get in your MRCOG part 3, right? So they are high risk factors. So remember to offer them. What would you offer them for screening, everyone? What would be the excellent, excellent. You would offer uterine artery Doppler at the anomaly scan. Okay. So these are all your maternal medicine stations in part 3 would be offered uterine artery Dopplers. Okay. Then,
Dr. Anita, sorry to
yes,
interrupt you. If it supports sickle cell disease, in which category I will go?
yes, of course, it is high risk category. It is high risk category. Any medical disease. Now they've given some examples, but they are not absolute, the ones that are given here. You can have more. So any maternal medical condition it is. Okay. So that would be, and sickle cell disease, as we know, is at risk of FGR, significantly at risk of FGR. So yes, you would do this in sickle cell disease as well. High
Yeah,
risk
but
factor.
yeah, you are right. Maybe also kidney involvement to a certain limit. But I
Yeah,
mean, what about asthmatic patient?
yeah, just sickle cell disease also would be a high risk factor. Okay.
Okay.
Then obstetric history. Previous, we have just said that previous FGR, you know that there is previously growth restriction. Definitely. This time also there would be growth restriction. Previous hypertension, this time also she is likely to have problems. Previous SGA stillbirth, we've already seen this. The above one is AGA stillbirth. This one is SGA stillbirth. Above is previous SGA. This one says previous FGR as a risk. Current pregnancy, PAPA, inhibin A, AFP. Okay, remember these are the screening for trisomy. Then echogenic bowel, EFW less than 10 centile, single umbilical artery would be ultrasound. Okay, so it's easy to remember. Current pregnancy factors is the screening ones and the ultrasound factors. Along with that, one additional factor, and there is significant bleeding. So you'll remember this medical diseases. Okay, current pregnancy factor is the screening for Downs. Those factors, PAPA less than fifth, inhibin A is high, AFP is high. Mid-trimester screen, echogenic bowel, EFW less than 10 centile, single umbilical artery. Okay, so these are the current pregnancy. Previous FGR is a risk factor of current FGR. So you start whatever you can. Previous hypertension, previous SGA, but still birth, right? And significant bleeding in this pregnancy and maternal medical history. Easy to remember. Okay, so these are the things that are considered as high risk factors. All right, so for them, you would do this particular chart as you can see. The first one says that if the uterine artery Doppler is normal and EFW is normal too, more than 10 centile, you would do ultrasound as we have seen from 32 weeks. Okay, now they have said every 2 to 4 weeks because they are high risk, no? So here it is every 4 weeks, right? Here it is every 2 to 4 weeks because it is, to begin with, it is high risk factor. Okay, now if it is normal uterine artery Doppler and EFW is less, okay, you do a serial ultrasound from 26 to 28 weeks. Okay, if it is abnormal uterine artery Doppler and EFW is more than 10 centile, you would start this, and this is almost the same. So you don't have to remember separate values as such. So you just remember if one of them is abnormal, you start screening from at least 26 weeks. That is what you need to remember. Now, this is an important question in the exam, in the part 2 exam. If it is abnormal very early, uterine artery Doppler is abnormal, AC is less than 10 centimeters. Both are abnormal. Both are abnormal. This is at the 18 to 20 week scans. This is at the anomaly scan, not later. So, if both are abnormal, you will discuss with the fetal medicine. Why? Why would you discuss with the fetal medicine? Anyone? What could be the possibility for early onset FGR? We spoke about it.
Maybe there is any
Normally,
placental insufficiency or congenital anomalies.
yes, it could be rather than congenital anomalies. Congenital anomalies, yes, the fetal medicine specialist would screen for abnormalities of organs. Of course, you will do a scan, and he would possibly consider invasive testing to know if it is one of the trisomies, the common ones. Okay, may not be Downs, but maybe Edwards or Pattaus, the common trisomies that are significantly associated with low growth or slow growth. Okay, so that is why early IUGR, early FGR is not common. So early FGR, when it happens, we need to suspect chromosomal problems. That is why you refer to fetal medicine. Further investigation. So suppose you have identified that there is a problem of growth. What are the further investigations that you would do? You would do check the fetal movements. Important. Always we ask our patients, how is the baby moving? Okay. In your part 3 stations, you ask the mother, have you named your baby? And the mother says John, and then you ask them, how is John moving? Remember? So that is what you need to do. Fetal movements. Next, computerized CTG is important. Okay. From 26 weeks, you can do a computerized CTG. This is different from the routine CTG that we do, because you check for short-term variability. What we normally check, the variability that we refer to, is not the short term. It is not the small beat to beat changes. It is the long term. It is the waviness on the CTG tracing. But here you check the short term variability. Okay. Then, so this is what you do. A maternal assessment. So check if mother has preeclampsia, blood pressure, proteinuria. And third trimester, if you diagnose fetal growth disorder, you can still offer uterine artery Doppler is what they are saying, not for the monitoring purpose, but to know whether it is placental dysfunction. Okay, it is also moderately useful in predicting adverse outcome. So this is just for diagnosis of placental dysfunction. This is not for surveillance. All right, so it may be offered even in the third trimester, just once, to know if it is placental dysfunction, because you don't use it for surveillance. Okay. Other methods that you do is this: placental growth factor and soluble FMS like tyrosine kinase and the ratio. And this is offered only for diagnosis of preeclampsia and to decide about delivery in preeclampsia. Okay, so it is not used otherwise. Okay, so what you would say is that it is not routinely recommended in non-hypertensive women. Okay, then you need to offer a referral to fetal medicine center. We have already seen this. If the VFW is below 3rd centile or below 10th centile with abnormal uterine artery Doppler at the mid-trimester scan, very early. Okay, so if you're very early, it's a small baby, you offer referral. See, invasive testing, SGA fetuses with structural anomalies, and in non-anomalous fetuses detected before, SGA detected before 23 weeks, that means very early, you have to do invasive testing. Especially if uterine artery Doppler is normal, because it means it rules out placental problem. Okay, so it rules out placental problem. So what they are saying is that if it is very early and baby is too small, placenta is also normal, what you need to suspect is a chromosomal problem. Okay, then analysis, as we had seen in the first lecture on genetics, microarray. Microarray is used for deletion, small changes in the chromosome, small gene changes. So you can do a microarray analysis in such patients. Okay. Then you will always do serological testing for CMV and toxoplasmosis in SGA babies, severe SGA babies, not all SGA babies. You will Fetal infections are responsible for 5% of, if you take all the SGA fetuses, 5% of those would be because of fetal infections. Remember that for MCQ. Malaria and Zika virus testing should be done only if there is, say, history of travel to endemic areas. Okay. So if they mention to you that there is a woman who's traveled to a country where the prevalence of malaria is high, say Africa, you would, and now she has SGA, you would consider testing for malaria. Okay. In congenital Zika virus infection, FGR is seen in 10% of the affected pregnancies. Okay, it is femur sparing pattern of FGR. That means femur is normal, but rest of the baby is small. So in Zika virus, 10%, that means 10% of those who have had Zika virus infection would have FGR. All right. And this is of all the SGA fetuses, 5% would have infections. All right. Most SGR, FGR is remember is because of placental problems. Okay, so very little is because of chromosomal, and your 5% is because of fetal infections. Now, so to summarize, what do we offer? A computerized CTG, blood pressure, proteinuria assessment. Uterine artery Doppler is only offered for evidence of placental insufficiency if it is not done already. Placental growth factors and soluble FMS like tyrosine kinase only in hypertension. So these are the investigations that you would offer. Then in severe FGR, referral to FMU, invasive if less than 23 weeks with normal, or if there is association with anomaly, CMV and toxoplasma, always in severe SGA, severe, okay? And high-risk cases, that is those who have gone to the countries where these infections are endemic, malaria and Zika virus. Okay. Surveillance, this is very important. Surveillance, how do we go about checking for SGA fetuses? Okay, as we can see, every 2 weeks ultrasound. So for screening or for say moderate risk factor, and you want to do surveillance, then it is, or screening basically, it is 32 weeks, then 36 weeks. But now you have already found a baby that is less than 10 centile. Next ultrasound should be at least every 2 weeks. And umbilical artery should be a minimum of every 2 weeks. It can be more frequently than this. It can be every week, depends on how severe the baby is restricted. Okay, but they say minimum, that means at least every 2 weeks. The frequency, minimum frequency should be every 2 weeks for an umbilical artery Doppler. Okay, so this is when you have diagnosed SGA. What we saw was screening. Okay, remember the difference. Now, okay. Now in EFW or AC less than 10 centile, where FGR is excluded, when do you deliver these babies? When FGR is excluded, that means there is no abnormal Dopplers, or the growth has remained, growth velocity is maintained. There is growth, but it is growing on the 10th centile. So this baby is likely to be just normal baby, which is just normally small. Such baby, you can offer an induction of labor at 39 weeks. Okay, should be delivered by 39 weeks, 6 days. This is important. So if it is just SGA without any problems, you can stretch the pregnancy till 39 weeks, induce at 39 weeks, and at least try to deliver by 39 weeks, 6 days. All right. After 37 weeks, you assess this particular baby after 37 weeks. Okay. And if there is now, as I told you earlier, remember in late SGA or FGR, you check the MCA, CPR, the middle cerebral artery. So if there is an abnormality in the middle cerebral artery or CPR, it can be used to decide about delivery. So if you have to deliver less than 39 weeks, a baby that is SGA, you check for Doppler, and now you see that there is brain sparing, or there is increased flow in the brain and reduced flow in the umbilical artery. In that case, you can consider delivery after 37 weeks. Okay. Induction of labor is not contraindicated in SG. You don't have to do cesarean for all. Right. CPR less than 1, Dr. Mahmood. Okay. Or CPR less than 5th centile is what the guidelines mention. Right. Okay. Now going to early FGR. Early FGR is, as we have already seen, is the severe variety, where the placental problem is so severe that you get absence of flow. Right? That is what we saw. So such babies have to be really looked after carefully. Okay. So what you do is you have to have tertiary level unit with highest level neonatal care. It has to be multidisciplinary care. An important point for part 3 exam to be said in your tasks that you're doing, that it has to be for severe FGR, it is MDT, multidisciplinary treatment. Okay, should be repeated biometry of severely growth restrict every 2 weeks, not more frequently than that, because this is biometry. I'm not referring to Doppler. Doppler should be more frequent. Biometry is growth, EFW, AC. That should be every 2 weeks. If you don't do more frequently, it gives you more false positive results. So you have to do at least every 2 weeks. Okay. Similarly, in SGA also, biometry is every 2 weeks. Doppler in SGA is at least every 2 weeks. It can be more frequent. Here in early FGR, how you do Doppler is decided on based on how severe the abnormality is. Okay, let's see. So in early FGR, frequency of assessment of fetal well-being is based on, say, severity of FGR and umbilical artery Doppler assessment should be at least weekly, but it can be more frequently when there are no other concerns, and 2 to 3 times weekly when there are abnormalities in the umbilical artery already. That means she's early FGR. Early FGR is always severe. So they require more frequent monitoring. A minimum of weekly monitoring if the umbilical artery Doppler is fine, but 2 to 3 times weekly monitoring if there is abnormalities in the umbilical artery. Okay? And there could be multiple modalities that you use, as we have seen earlier. You have absence of end diastolic flow, reversal of end diastolic flow, and then in early FGR, you cannot just directly deliver them because they are too preterm, and every day in utero may help them. So you wait till the DV Doppler becomes abnormal. Okay, the DV Doppler becomes abnormal, but that means the baby's heart is starting to fail. That's when you consider delivery. Okay, so it is either DV Doppler or CCTG. CCTG tells you how the baby is doing right now. Okay, so MCA CPR can inform monitoring strategy and frequency, but MCA CPR should not be used to determine birth decisions prior to 37 weeks. MCA CPR is used after 37 weeks to decide about delivery. Is that very clear? Early, your umbilical artery Doppler, very early FGR, umbilical artery Doppler. If it is absent, then you or reversal, you do a DV Doppler. As simple as that. Late, of course, you use your umbilical artery Doppler to look for changes. And if the PI is more than the 95th centile, you would consider delivery early. But MCA Doppler is considered for delivery after 37 weeks. Late FGR. In FGR, in pregnancies with FGR, if they are late FGR now, okay, if early FGR, you have to deliver them somewhere depending on the DV Doppler abnormalities, depending on CCTG abnormalities in early FGR. Okay, that has to be very clear with all of you. Early FGR is very severe FGR. You cannot wait till 37 weeks. So you have to deliver them based on your CCTG, based on your DV Doppler. Okay. Now, if it is late FGR, delivery should be initiated from 37 weeks to 37 weeks 6 days. This is for FGR. SGA you can wait till 39 weeks. FGR, that means there is EFW less than 3rd centile or EFW less than 10th centile, or with umbilical artery Doppler changes, or CPR less than 5th centile. At least you deliver by 37 weeks 6 days. In late and term FGR, assessing the ductus venosus waveform is unlikely to be informative, as it is very unlikely to show severe abnormalities. This is what the concept tells you. When it is severe abnormality, it reflects on umbilical artery in the form of absence of flow, and that reflects on the baby's heart gives stress to the baby's heart. The heart is not able to pump adequately. That results in backflow. That reflects in the ductus venosus, which is supplying to the baby's heart. So when it is very severe, it reflects on ductus venosus. So when the very fact that your pregnancy has reached too late gestation, it means the severity is not so much. Okay, and that is why you rely on your umbilical artery Doppler and your MCA Doppler. Very simple to understand. Okay, and if you understand this, you will never forget your FGR. In pregnancies with late FGR, birth should be based on fetal well-being assessments and maternal indications. That means if she has severe preeclampsia, you deliver. You don't wait. Okay? Like more than 34 weeks, severe preeclampsia is preferably delivered. Okay? You do not really wait. Now, in the SGA fetus or late FGR fetus with normal umbilical artery Doppler or with abnormal umbilical artery PI, but end diastolic velocities are present, IOL can be offered. In SGA, we know that IOL can be offered safely. But in FGR, we are a bit worried if there are umbilical artery Doppler changes. But if there is positive flow, what is positive flow? This is the baseline. Umbilical artery is always having flow and during systole and diastole. Absence is this. During diastole, there is no flow. This is absence of flow. Reversal is this. During diastole, it goes backward. So if there is positive flow, that means there is, say, it is mentioned 95th centile and more, but that means it is positive flow. Otherwise, they would have said absence of flow. You can offer induction of labor, but the rates of unplanned or emergency cesarean birth are increased and continuous fetal monitoring is required because these babies are compromised. They may not withstand the stress of labor. That is why even if you can offer IOL, you need to monitor them well. And when you monitor them well, you may find abnormalities in the fetal heart, because of which you may need to consider a cesarean section. And it is preferred that you offer induction with mechanical methods because your prostaglandins can cause hyperstimulation, further compromising the circulation to the baby. Okay, this is all logical. Early admission is recommended in women in spontaneous labor because again, if the contractions start, the placental flow may get compromised, and that is why you need to check CTG continuously in labor for such babies. That is why you tell them to get admitted early when their contractions start. Simple as that. Okay. Let's look at this. All right. So this is a quite complicated a chart. Now, just look at early FGR, late FGR. Early is here, less than 32 weeks. As we said, early, less than 32 weeks, what problems that we can expect and when to deliver is umbilical artery showing absent reversal of flow. And when umbilical artery showing absence reversal of flow, we have said earlier that we will do CCTG and DV, which is used for deciding delivery. So up to 32 weeks, which is early FGR, you base delivery decisions based on your CCTG and your DV. Short-term variability is CCTG and DV A-wave absence is used for delivery. All right. They also said that if there is absence of flow, you can stretch the pregnancy maximum till 34 weeks, not more than that. Yeah, 34 weeks. And consider delivery by 32 weeks. So if there is a baby at 32 weeks, you have done a Doppler umbilical artery and you have found that baby is having absent flow. What would you do? Anybody? What would you do?
Absent flow will deliver by 34 weeks, ma'am, but consider by 32 weeks.
So now if I'm giving you a situation that 32 weeks she's come to you, she has growth restriction. Her baby is having, say, growth at 10th centile and she's absent flow. What will you do?
Twice weekly CCTG and ductus venous Dopplers, ma'am.
Fetus.
Yeah, don't you want to know it, the ductus venosus now? Why would
No,
you
yeah.
already decide twice weekly? First do now and see if there is absence of DV, isn't it? So the next
Yes.
step would be DV and CCTG. Okay.
CCT.
Now,
Continuous.
why they have said consider is, say the patient has come at 32 weeks, absence of flow, and a patient has preeclampsia, or the baby is not moving well. These are concerning factors, right? So in such a situation, you can consider by 32 weeks. But otherwise, if everything seems fine, you will take the pregnancy ahead at least till 34 weeks is what they mention. But again, remember strictly that 32 to 34 weeks is a gray area. So if you have given the baby the necessary precautions that we take at this stage, like what are the precautions that we take at this stage if that baby comes? What else are you going to do? That same baby.
Fetal movement daily.
Okay. What
And
else?
monitoring of the blood pressure and the protein in the urine.
Yes. Yes.
High blood.
What are the other factors? What do you need to do? Why do you need to wait? What would you do at 32 weeks with severe? Excellent. You need to start steroids, right? And how do you give steroids? You have to give steroids over 2 days, not just one shot and over. You have to wait. So if you say, for example, it's 32 to 32 or 34 weeks, you have given steroids and the baby is doing fine. You can, but the Doppler is showing reversal of flow. You can consider delivery because you have already given the necessary precautions. Why wait when the outcome is not always clear? They've also mentioned in the guideline that we must remember that there can be sudden deterioration in the baby's condition. That is why you consider delivery by 32. So look at the other factors. If you have not given steroids, if you have, if there are no other problems that requires immediate delivery, you wait, you give steroids, and then see on a daily basis how the baby is behaving, and then deliver. Okay, so that is what it means when they say consider from 32 weeks and deliver by 34 means don't really wait for 34, but you cannot go beyond 34. That is risky. Baby can die. Okay, so absence of flow before 32 weeks, it is very easy. Before 32 weeks, you wait for DV Doppler to be absent, or you wait for changes in CTG. Like they have mentioned that between 26 to 29 weeks, it is less than 2.6 milliseconds. 29 to 32 weeks, it is less than 3. 32 to 34 weeks is less than 3.5. It's, you can consider it 2.5, 3, 3.5, 4.5. That is how you can remember it. But I don't think they will ask you these values. Okay, so but if you can remember, then it's simple to remember also. 2.5, 3, 3.5, 4.5. Okay, but you will not get a question asking the values of STV at the gestation. Okay, so what you need to remember is less than 32 weeks, decide delivery based on doctor's diagnosis. And between 32 to 34 weeks, it's a gray area. So even if absence and reversal, you can consider delivery. More than 34 weeks, as we have already discussed, you are less likely to get absence, but you may get. Okay, but otherwise you deliver, as you can see here, 34 weeks and above by 36.6 weeks if PI is more than 95th centile in the umbilical artery. Okay, and in FGR, 37 to 38.6 weeks, you deliver, as we have already seen, FGR should be delivered by 37.6 weeks max. When all these other factors are not there in that baby, you take till 37.6 weeks. It is not more than 95th centile, say. It is not having absent, or absent will not reach your 37 weeks at all, but it is not more than 95th centile. You wait, but it is FGR, say it is less than 3rd centile, the EFW. Then you deliver by 37.6 weeks. Okay, so if umbilical artery is more than 95th centile, you deliver by 36 weeks, 6 days. Okay, and if there is signs of cerebral redistribution, you deliver after 37 weeks. We have already seen after 37 weeks, we look at the CPR. Okay, SGA babies can be delivered by 39 weeks, 6 days. We've seen this, right? So let's do one thing. Let's make it very easy. Absent A wave in DV after doing after doing a umbilical artery Doppler, which is showing absence of end diastolic volume. These are delivered. If you find this abnormality and the baby is of this gestation, you deliver. Yeah, by 32. Anywhere you find absence of A wave, you deliver. Okay, you deliver the baby. Whether it is at 27 weeks, whether it is at 28 weeks, whether it is at 29 weeks, you deliver, not just 32. Okay, simple. This is the range, right? Let's see again. This is the range. Okay, 20, not this, not 24, sorry. Okay, this. Okay, this is too high, but this. Okay, so if you find that abnormality between 26 to 33 weeks, 6 days, you have to deliver no matter what. If you find only absence of umbilical artery or reversal, you consider delivery by 32 weeks, absolutely by 33.6 weeks, absolutely. You cannot go beyond, it's criminal to go beyond 34 weeks. Okay? Okay. Reversal of umbilical artery, yeah, this is absent, this is reversal. Reversal is 2 weeks lesser than absent. That is, consider by 30 weeks, absolutely by 32 weeks. So if it is reversal, you will not go beyond 32 weeks. Never beyond 32 weeks. If it is absent, you will never go beyond 34 weeks. Never. Okay, deliver by 34, deliver by 32. Doesn't mean you should not deliver less than that. Less than that, you look at other factors. You look at whether you have given her steroids, you have not given her steroids, whether mother has any condition that needs delivery, whether she has good fetal movements or not. If all of these factors are fine, you can continue the pregnancy. If umbilical artery PI is more than 95th centile, when do you deliver? When do you deliver?
6 plus 6 weeks, ma'am.
Excellent. AFW less than 3rd centile. Other things are normal. So this is not there, this is not there, this is not there. When do you deliver?
39 plus
7.
6.
Who said 39?
37, not 39.
30.
Who said 39?
Okay, that is only SGA, ma'am. Okay.
Okay, do not make that mistake. So this is 37 weeks, 6 days. This is FGR, right?
Yes, yes,
FGR baby can also have this. If there is this, deliver at 36, 6 days. FGR baby may just have less than 30, less than 3rd centile. Umbilical artery Doppler may not be more than 95th centile. Those babies deliver by 37.6 weeks. 37.6. SGA, no other factor. So this is not there, this is not there, this is not there. Only less than 10 centile. Deliver by 39 weeks, 6 days. By 39 weeks, 6 days. Start delivery at 39 weeks. Try to deliver within that week is what they are trying to say. Okay, so this is the important slide from this presentation. Okay, yes, do not go beyond 40 weeks. Then antenatal corticosteroids is what is recommended between 24 to 34 weeks, 6 days. Ideally, see, 48 hours before the birth is anticipated. So if you have somebody who's coming at 32 weeks with absent end-diastolic flow, you will give steroids. You will wait for steroids for at least 48 hours. That is why it is something that you need to look at as a gray area. It is difficult for you to continue the pregnancy as well when there is absence of flow, and 32 weeks is a salvageable baby when you deliver, right? So it is a difficult decision in the sense that you can get stillbirth anytime. That is why you have to look at all these factors. So if steroids are not given, you make sure that the steroids are given, and then you deliver the baby after 48 hours. In utero transfer is for all preterm births. You need to transfer them to a unit with appropriate neonatal cord facilities, and when it is safe to do so. This is a typical station in Part 3 MRCOG. If there is a possibility of preterm birth, you should refer to a unit where there is a neonatal cord facility. And the level of neonatal cord facility would depend on the extent of growth restriction, the extent of prematurity, both the factors. Okay, and when it is possible or safe to do so means the patient should not be in advanced labor. She should not deliver while you are transferring the baby, the patient. Okay, babies less than 27 weeks, EFW less than 800 gram, should be born in a unit with neonatal ICU. Yes, this is level 3 ICU. Okay, ensure that the neonatal team are involved when a preterm birth is anticipated. Level 3 ICU is for less than 27 weeks and less than 800 gram. But remember, that doesn't mean any baby that is more will not require level 3. May require level 3, may or may not. Okay, so it cannot always say that this particular baby may not require. Say you are trying to umbu the baby and baby develops a pneumothorax, you will have to shift her to an ICU, isn't it? So you cannot really say that, okay, this baby will require level 2, this baby will require level 3. Okay, so it depends on the degree of invasive techniques that are available. Postnatal investigations and pre-pregnancy counseling. You need to do a histopathological examination of all FGR. When there is FGR, you test the placenta. Okay. Women who have given birth to a growth-restricted fetus should be offered appointment for postnatal counseling. This is important for Part 3 stations. Offer them counseling. Okay. Check what their histology is and talk to them about acquired thrombophilias, the underlying causes. A plan for future pregnancies and preventive strategies should be recorded in the notes of. So if there are any risk factors that you identify in a particular task that is given to you, then you need to say that I would like to offer you, say, for smoking cessation, you would say NHS stop smoking services, etc., or aspirin in the future pregnancy. Okay, this may also come as a potential SPA question in the Part 2 exam. All right. So this is all in brief, the entire guideline that is summarized, right? It's very simple. What you need to remember is early FGR, late FGR. Early FGR is less than 32. Late is more than 32. That means it starts more than 32. Early FGR, the modalities of surveillance is absence, reversal, ductus venosus, CTG, and based on the findings you deliver, mostly you will deliver definitely if it is absent A wave on DV, absence of A wave on DV Doppler, and you would deliver by 34 weeks, by 32 weeks for absent and reversal of flow respectively. If it is more than 32 weeks, if you monitor umbilical artery PI is more than 95th centile, deliver by 36.6 weeks. If you monitor and it is FGR, that is less than third centile, this is also FGR, but here there is no severe Doppler abnormality. This is a severe Doppler abnormality. This can be delivered between 37 to 37.6. If it is SGA only, that is less than 10 centile, you deliver by 39.6 weeks. So the entire guideline is in this slide. Is this clear? Any questions, please? Any questions? Can I assume that it is all clear to all of you? Right?
Yes, ma'am.
Yes, ma'am. Thank you.
Thank you. Thank you for your patient listening. All right. So we wind up for the day. Thank you. Good night.
Thank you.